Hey everyone, welcome back to Static Pharmacology here on EMTV. Unlike Static Cardiology, I'll be presenting you with just a patient care scenario. Your goal is to develop a medication treatment plan to fix this patient. For an extra challenge, I'll be putting a 1-minute timer on the bottom of the screen. When this time is up, we'll go through the scenario walkthrough and then on to the treatment. Enjoy the card and good luck.
3, 2, 1.
So in this card, you're presented with a patient who's clearly having an allergic reaction. Now, is this a simple allergic reaction, or is this anaphylaxis? Let's go ahead and take a look at the scenario, and we'll make our determination based on that. So we're dispatched to a private residence for a 31-year-old male complaining of difficulty breathing. Upon arrival, we notice that the patient's lips are swollen, and there are hives visible on his neck. He reports that he's allergic to shrimp and states that his symptoms began shortly after eating prawns. Now, it's important to note that although these are different species, shrimp versus prawn, they are still both considered shellfish. And just a fun fact, cicadas are also known for triggering anaphylactic reactions for those who are allergic to shellfish when consumed, and this is because they actually contain the same protein responsible for the allergic reaction. We found this out last year during the large brood of cicadas in the DC metro area, and there were several very trendy pop-up restaurants that appeared in Washington, DC selling cicadas, and people who had known shellfish allergies assumed that they were different enough, ate them, and then actually went into anaphylaxis. Your partner obtains the following vital signs: blood pressure 84/50, pulse 124, respiratory rate 26, and SpO2 of 92% on room air. He denies any pain but reports a tightness in his throat. Lung sounds are diminished, but tracheal auscultation reveals the presence of inspiratory stridor. So to answer a question from earlier, based on what I'm seeing here in the scenario, this patient definitely is in anaphylaxis. It's important to remember that anaphylaxis is a form of shock, or hypoperfusion, and his vital signs clearly paint the picture of someone in shock. Additional criteria for anaphylaxis versus simple allergic reaction would be the involvement of more than one organ system, which this patient clearly has. Next, we'll move on to the treatment. And remember, it's important to note that we're not going to go completely into the weeds here as far as treatment algorithms are concerned. These are common medications that you would give for a patient suffering from anaphylaxis. Let's now go ahead and take a look at that treatment algorithm. Just to keep things familiar, I'll begin my treatment like I begin treatment for all my Static Cardiology cards by regurgitating the mantra, scene safe, BSI, IV O2 monitor. Because this patient is in anaphylaxis, the most definitive medication treatment that you can give this patient is epinephrine. So we'll be administering epinephrine, the 1 to 1000 concentration, and we'll give a dose of 0.3 to 0.5 milligrams, either IM or sub-Q. And this can be repeated every 5 to 15 minutes as needed. The next medication I'll use is an H1 antihistamine, diphenhydramine, and I'll give a dose of between 25 to 50 milligrams IV. I'll follow this up with a corticosteroid. The most common one available prehospitally is methylprednisolone, otherwise known as Solumedrol. Standard adult dose for this is 125 milligrams. I'll then add an H2 antihistamine. H2 histaminic reactions tend to involve mostly the gastric tract, so I'll be giving famotidine 20 milligrams IV or ranitidine 150 milligrams IV. These are known as Pepcid and Zantac, respectively. If you don't carry this pre-hospitally, not a huge deal. I'll then consider administering glucagon. Now, glucagon is an interesting and I believe pretty underrated medication. Glucagon wouldn't technically be applicable in this guy's case, but in someone who takes beta blockers for blood pressure control, generally the epinephrine that you're going to administer won't be quite as effective because of the beta blockade that's occurring because of the blood pressure medication. So we'll administer glucagon to kind of circumvent the beta blockade. What glucagon does is it actually stimulates the production of cyclic adenosine monophosphate, or CAMP. CAMP is a secondary chemical messenger that basically will allow epinephrine to be used by the cells, bypassing the beta-2 receptor sites. So you're going to get the bronchodilation that you need, and you're going to actually be able to use the epinephrine appropriately. So it makes your epi more effective, especially in individuals who are taking beta blockers. I could then consider giving albuterol 2.5 milligrams nebulized, and this can be repeated as needed for any sort of bronchospasm that might be present. IV fluids, of course, and then an epinephrine infusion. This is hung at 2 to 10 micrograms per minute. And of course, rapid transport. And that's it. If you like this card, please make sure to subscribe to my channel for more. And again, I want to thank you for watching. Until I see you next, please keep washing your hands. Have a good rest of your night.